Hi everyone, welcome to the next panel, which is Benefits of Microdosing, Profound or Placebo. My name is Brad Adams and I'll be the moderator. I'm the founder and CEO of LAMPS, the Los Angeles Medicinal Plant Society. And I was also the co-chair of the Los Angeles Psychedelic Science Symposium back in 2018 in UCLA. And
Hi everyone, welcome to the next panel, which is Benefits of Microdosing, Profound or Placebo.
Okay.
My name is Brad. With this Los Angeles Medicinal Plant Society. I was also the co-chair of the Los Angeles Psychedelic Science Symposium back in 2019 in UCLA. And everyone, welcome to the next panel, which is
It's my honor to introduce the stellar members of this panel. So first of all, I'd like to bring up Olga Chernoloz.
With this Los Angeles Medicinal Plant Society.
Hi, Olga. So as a trained neuropharmacologist and registered pharmacist, Olga has held a number of roles in management, drug development, biotech, and pharmaceuticals. Dr. Chernoloz is a specialist in the pharmacology of psychoactive compounds. Is that echo on my side? Do you hear an echo, Olga?
So first of all, I'd like to bring up
Dr. Chernoloz has developed a program for continued medical education in psychedelic medicine. She's the Chief Science Officer at Wake Network and a scientific advisor to the Psychedelic Studies Research Group at the University of Toronto. With Wake Network, Olga is pursuing structured clinical research on psilocybin, micro and macrodosing. Olga the potential of psychoactive drugs in the treatment of mental health disorders and improvement of quality of life in healthy individuals. Welcome, Olga.
Wonderful to be here.
She's authored a number of research articles and a chapter in instructional book in neurobiology of mood disorders. And she's also has an upcoming microdosing study, which she'll be talking about later. So excited to hear about that. Next up, we have David Erritzoe. David is a clinical senior lecturer and consultant psychiatrist at Imperial College London and CNWL Mental Health NHS Foundation Trust. David conducts pharmacological research using brain imaging techniques such as PET and MRI. He was trained in PET imaging at Columbia University in New York and later undertook a PhD at University Hospital 𝗏𝗏𝗃𝗏𝗃 in Copenhagen. Since 2009, he has been involved in postdoc imaging research in the neurobiology of addictions and major depression at Imperial College. As a clinical director at the Center for Psychedelic Research, he investigates mechanisms and therapeutic potential of MDMA, ketamine, and classic psychedelics, together with Professor Nutt and Dr. Carhart Harris. And in early 2021, David set up a new NHS-based psychopharmacology and psychedelic research clinic at St. Charles Hospital in London.
I'm sorry, Brad. Can you hear me?
State Micro and co-founder of Microdosing Movement and Macrodosing Support Network. He works daily as an educator, coaching clients on performance enhancement, diet, meditation, neutral thinking, and flow state optimization. Bramlage spent more than a decade as an advocate, farmer, and distributor and manufacturer in the California legal cannabis space. He sold his cannabis companies and pivoted into psychedelics after successfully using microdosing to cure his own treatment-resistant depression and enhance his physical and mental performance. So welcome out. So welcome everyone. I think this is going to be a very interesting panel because this is a very hot topic right now, which you all know I'm preaching to the choir. Just like to say, like you and probably everyone else in the audience, I was very excited to see all the stuff going on with microdosing early on. A lot of anecdotal reports coming up, a lot of claims of pretty substantial gains from these types of medicines. So when this study came out through Imperial College, it was kind of not sure what to make of it and hope we can unpack a lot of that, but it's going to be fascinating to kind of tease this apart. But first of all, I'd like to just start the discussion with what exactly is microdosing and what are some of the gains that have been seen up to, so far through anecdotal reports and other sources. So I thought maybe we start with Adam. Would you mind tackling that first, Adam?
Yeah, absolutely. Thanks.
Microdosing and what are some of the gains that you've seen you yourself and other people have gained from this?
Thanks for having me. So a microdose is 1/10 to 1/20th of a substance. It can really be any substance, but today we're dealing with psychedelic substances. So when it comes to microdosing, usually 95% of the people are going to be microdosing either LSD or psilocybin. So that's what we're going to be talking about today. So again, a microdose is a 1/10 to 1/20th of a normal dose of a substance. When it comes to microdosing, usually I think you're still muted, Brad, if you had another question.
Thank you. Is my mic back on? Thank you very much for that, Adam. Great. So now I'd like to just jump right into the research done at Imperial College.
Microdosing, usually.
So David, first of all, thank you for being here, and congratulations on this very amazing study. Yeah, I'd just like to thank you, Adam, for that, and I'd like to just jump right into the Imperial College study. So it was a fascinating study, I thought, David, in a lot of different ways. So would you mind just giving us a brief overview of what was done, how it was done, and then we can jump into some of the findings and discuss what they mean?
Yeah, thanks a lot for inviting me on. I did present it yesterday, so some people might have seen that in more detail, but the super brief version is that we sort of developed together with 𝗏𝗏cie, who came up with the idea that created this manual that people would follow. So if people plan to do microdosing with a classic psychedelic of their own initiative, using their own drug anywhere in the world, they could sign up to the online platform and give their consent for us to collect data and participate in sort of a game where if they followed the manual, basically they were creating all the doses in capsules that they were planning to do, but then they also did a sort of mirrored version of placebo capsules, and then they were put into bags together with some labels, and then they ended up in envelopes. And so people were it was a 4-week microdosing regime period, which is sort of quite typical that people sort of choose to microdose for a month and see how it goes. And so each envelope they created represented 1 week, and in each envelope there was a QR code that we had generated, that printed out and put it in. And that meant we could follow it. If they scanned it each week on an app, we then knew what was in the envelope. So they created double the number of envelopes needed. So instead of 4 envelopes, they created 8, and then mixed them in a particular way so that they would end up in one of 3 groups in the study randomly. So that either they would be microdosing for the full period, so every week over the 4 weeks, or they would do placebo for every week over the 4 weeks, or they would be in a mixed group where they did microdosing, placebo, microdose over the 4 weeks, so one each, 2 weeks of each condition. And then we, on the online platform, there were cognitive tasking on a regular basis. There were different well-being scales to self-rated, validated measures of that, and also psychopathology measures, depression, anxiety, and mindfulness, and tons of other things. So they did that, and then they also, every day when they had taken a capsule, without them knowing what it was, we also asked them to guess what they thought and how certain they were about that. So we also collected that kind of information. So we had the ability to do both between subject comparisons, meaning between the groups who had been microdosing and then not microdosing. And because of the little bit, I won't go into too much into detail why we could do that, but there were also placebo put into the microdosing conditions, so we could also do within subject comparisons and so on. So we could compare quite a lot of different things. We could look at the accumulated effects over the full period and also an extra month follow-up. And then we could also look on the sort of dosing days, how people were doing, and relate that to whether they guessed they took an actual microdose or whether they thought it was placebo. So that was the design of the study. So basically a self-blinding citizen science new methodology that could be used for a lot of things, including testing cannabinoids and other things that people do on large scale anyway, and is not necessarily that difficult to test, but expensive and sometimes difficult to test. The psychedelics, microdosing, it's difficult to set up because you can't just give people in most places the drugs to take home. And that means it's complicated to conduct those trials at this stage. That's why the microdosing science is mainly at the moment consists either of acute doses where you measure the acute effect, single dose, different doses, which is great, but it's not really the same as what people are doing out in real life where they're doing it repeatedly over a longer period. And if you do that kind of trial and have to have people coming into a lab constantly instead of going to work, then it's complicated. And also they're out of context from where they would be normally, and that makes it different to normal drug studies. And not brilliant actually. So of course, if in New Zealand they're setting up a trial where they can give people a few numbers of capsules home and stuff, that's great, and hopefully that will be possible in other places as well to conduct such trials. So now I haven't said anything about the results, but I'm speaking too much, so I'll maybe stop there unless you want me to talk about the results now as well.
Yeah,
up to you.
First of all, I just I think it's a brilliant and very creative design, and I think it's kind of a game changer. I'm excited to see what else comes from this in terms of doing this type of research, because as you mentioned, you get this is a lot cheaper way of doing it. You sacrifice certain things with it, but you gain a lot as well. So this type of research is very valuable. So first of all, just kudos to that. Yeah, let's just go ahead and jump right into the results, because that's the most interesting part of this whole thing.
Yeah. So if you let's just start focusing just on the people who were actually microdosing. So forget about the placebo group. If you look at that data, it basically confirmed all the anecdotes, all the best-selling books, and all the prospective, all the retrospective non-controlled trials by showing that people felt better, decreased in anxiety, depressive symptoms, increased in well-being, increased in mindfulness, increased in everything that you had been shown before. So in a way that confirmed all those studies showing the promise potentially. But then when we look at the placebo condition, then people also improved and it didn't separate. So that means there were no statistical difference between those groups. So basically a negative trial if it had been a real drug trial. And then we can also calculate, in order to actually see difference, we would need sometimes thousands of people, depending on what measure we're looking at. So basically a negative finding. Then in order to make sure what we were dealing with, because that obviously shows that it does have an effect, but it's just driven by placebo most likely, because if you have the same when people thought they were taking microdoses, then it points towards a placebo expectation effect. And then when we looked at the other kind of data in the trial where we asked people to guess, we could then do some sort of mathematical modeling of the data and see that the effect of guessing you took a microdose was 10 times more significantly predictive of the positive outcomes than what actually was in the capsules. So that means two different ways of looking at the data, because and different aspects of the data pointed in quite strongly in the same direction, that it was the incredibly important component of it is expectation and placebo. So that was our trial.
First of all, what was your initial reaction to finding those results?
A bit mixed, because I mean, if you think about on a greater scale and scope for humanity and people suffering and not being sufficiently treated with the normal tools we are using in psychiatry, I'm also a psychiatrist, and a lot of people don't respond to the treatments. If there was something that could really help, then obviously that would be amazing. And if people would take small doses with minimal or even any potential side effects, and if it had proper effect beyond placebo, that would be extremely promising. So in that sense, it's disappointing. On a scientific level, I think it's quite satisfying when all your data is relatively easy to conclude on. So in a way, it was pretty clear, the data, and in that way, it was very interesting, and so we got quite enthusiastic about it, although it was disappointing for the field and also to some degree for ourselves, because the idea with such a trial was that it could obviously be used for grant proposals as pilot work and then really get investments in to really conduct big trials. The good thing is that has happened anyway. Companies are obviously doing it, and that's great. So it's not that we have totally block the whole thing just with this study. You also can't conclude based on one study. It's not perfect science. It's not a proper randomized trial. We can't measure what people in Buenos Aires signing up for the study was actually ingesting. It could be that they had their LSD lying in a window for the last 10 years and there was nothing left in it. You never know. So we are trying to close the gap by doing a second phase of the trial, London-based, where we can hopefully test the compounds and do neuroscience and see if we can replicate or see what it shows. So we are expanding the research so mixed in terms of
A couple of quick follow-up questions. So I looked quickly through the paper and I noticed that most of the participants were using LSD or LSD analog, and only about a quarter maybe were using psilocybin. Is that correct?
Yeah, that's true. There were more people using LSD than psilocybin. Yeah, but when we looked at those two, it didn't differ. And very importantly, I think because people are saying, yeah, they were healthy in this trial. So what about in depression? That's also a totally valid question to ask. But we did try to then dive in and look at a sub-fraction of the participant who scored high at baseline. So they had some degree of depressive symptoms or high neuroticism. So everybody who was sort of in the space of being either having high vulnerability or had a depressive, and that again, the data were not different in that group either. Again, disappointing for this sort of potential of developing these dose ranges on repeated basis for depression, for instance. Doesn't mean that it won't work in a proper big trial, but it does not show promise. And remember that it really did with the full doses. Also, when you looked in healthy, it massively worked. And of course, the million-dollar question is, what about the full doses? You can't blind them probably. So it opens a lot of questions also for SSRI research and a lot of things about guessing. So it opens more questions than it answers, but it's interesting. We
As
thought.
you mentioned, the bigger macrodose studies, I'm reminded of the Chapel Hill study that was done back in 1962. They gave half people psilocybin, half niacin, and it always seemed almost a little silly to me. Like, you can't tell the difference between like a little tingling and something that's overwhelming. But and I know it's what you need to do, and I'd like to talk a little bit more about placebos a little bit later. But I want to move on a little bit too. And thank you for that, David. Olga, what before you talk about your research coming up, can you just give your reflections on the Imperial College findings?
It was an interesting study and necessary start. And considering that it was conducted in the confounds of microdose substances being controlled substances and all the challenges that David has mentioned, it was the best that it could be in the given conditions. And as David said, it probably posted more questions, and as an industry, we have resources to tackle and answer some of these questions. So with the 𝗍𝘀, we are planning a number of fairly large-scale randomized placebo-controlled microdosing trials where we will be able to answer a lot of these questions. And what's interesting and what sets our studies apart is that we will be using mushroom-based psilocybin, unlike all the other controlled trials that were done with the substance before.
So it sounds like you have doubt as to whether or not it is all placebo, obviously, if you're going forward with a study. Is that correct to say?
Yes and no, and I don't want to give a placebo a bad reputation. We tend to equate it with nothing, and it's not. The placebo effect is a real measurable thing. And if through microdosing we can somehow boost the internal capacity for positive self-change, all the better. However it works, if it works, we'll be able to give people something that they badly need, considering the high safety profile of the substance. I don't see why not. And again, we need to do some long-term studies because there are concerns about potential organ toxicity, but it all starts somewhere, and the only way to get there is through proper controlled research.
And where can people find more information about this research coming up?
Our first microdosing trial that will be conducted in Jamaica is now under review by NIH and will be posted at clinicaltrials.gov once they clear the review. And I would put anybody interested in quality trials to clinicaltrials.gov or a European equivalent to see for the what controlled studies are taking place. And now I guess there is so many press releases coming out from so many companies that if you are tuned into the industry and this topic, you will just hear about it before it actually happens.
Thank you. So Adam, I know in your bio, you'd mentioned that you've received a lot of gains from microdosing and done a lot of work in this area. So I'm curious to know your reactions to this. Do you think the gains that you got were primarily driven by your beliefs that it would help you?
Well, there's two things I know for sure. Number one, we're not going to figure out if it's placebo or not today in this talk, so I'm not going to really get into a debate. And number two, we need more clinical trials, and we need trials that aren't self-blinded, self-dosed, and self-administered. We need to know that if we're summing up microdosing, that they're actually taking LSD, and it's not LSD that's set on a window pane. Or matter of fact, their brother gave them Visine or water instead of LSD as a whole. So I think we need more controls, we need more clinical trials, and I'm really appreciative of David's study because, again, we do need some negative press about microdosing. If everything that's always coming out is how great it is, it's maybe not a fair and equal shake at the topic. So I applaud him and the study and all the other studies he's been a part of, pushing psychedelic research forward. And I think we need proper studies. I know in my life, it's been extremely helpful for myself. It's helped my 72-year-old mother, who was a nurse for 50 years and would have never thought of using psilocybin mushrooms. She was Western medicine the whole way. Today, before the talk, I ran into two clients at the grocery store, one of which it helped with severe bleeding during menopause. She was looking at having her uterus removed. Microdosing helped stop the bleeding within 6 weeks. And I asked her, what would you say if someone said that was placebo? And she laughed and she said, well, I would tell them I tried everything else. And I would show them all the things that the doctors prescribed for me. And the fact that once I started using these microdoses of psilocybin, it actually helped to regulate and slow down the breathing. Her boyfriend has had eczema for 30 years. Microdosing has been the only thing that has helped his eczema. And I think it's unfair to say that these people who've suffered from these lifelong conditions with no help have tried everything possible, included positive thinking and being their own placebo effect. So I'm looking forward to more trials and knowing exactly what the person is getting, knowing the exact dosage. And again, we have a long history of using small mini doses in psycholytic therapy that started in the 1950s, where they were combining mini doses with therapists. So again, I don't think it's fair to say this one self-dosed study of 191 people should sum up microdosing. But at the same time, I think it's good and it furthers conversation, and we need to do more research into this.
Excellent points there, and thank you for that. Yeah, I'd like to talk a little bit more about the placebo effect because, as Olga mentioned, it's kind of has a bad name, bad reputation as being nothing or the but it's not nothing. Obviously, it's a lot because otherwise people wouldn't include a placebo group, and that's the way industry decides whether or not to market a drug or if it's effective. So, I remember one time Andrew Weil was talking about wart cures and how simple things like you tell someone you rub a cucumber on a wart, it'll work, and then the next day it falls off. Really weird things like steal something from the refrigerator, don't tell me about it, and the person did that and the wart fell off the next day. And so power of the mind is extremely amazing. So in one way, we want these clinical trials to show that there is an effect above that, but on the other hand, talking about placebo in a positive way, what are some ways we can use placebo in terms of helping people clinically and in other areas? Anyone have some thoughts on there you'd like to share?
A lot of thoughts. We probably all have a lot of thoughts about that. I mean, I can be such a party pooper, cynical medic here, but I'm in the conventional medicinal world, and as a medic, yeah, I mean, placebo is a thing. It obviously is, and it's very important. It's also deeply fascinating, and yes, it sits with a lot of the effects of a lot of treatment. So that's a given. However, if something can't be shown to work above that, then it's not very likely to have a future in the conventional medicinal space where medicines are approved and put into guidelines and being prescribed in the conventional systems by medics such as myself and many others. I mean, so as fascinating it is, if it's just placebo, it's just not enough for going through an approval process. And also, if more and more studies, if it was going that direction, that they all show that it doesn't work and doesn't separate from placebo, then at some point, some of the enthusiasm and the optimism would then also go off, and the whole placebo would go down most likely. At the moment, there is all ingredients in the world to create a massive expectation effect. You are part of a new movement, very optimistic, coming a lot from the full dose research. Michael Pollan's book, research by Johns Hopkins, our own team at Imperial, many others. A lot of fantastic reports and good science coming out there. There's something a little bit, and a lot of people establishment, anti-medicine, anti-doctor, anti-big pharma. It's back to nature. You're the cool kid in Silicon Valley when you go to work at Google and talk about you belong to a subgroup, a community. I'm just saying, it just has everything. It's hyped. It has everything that would create. Also, you need to make a lot of effort, even doing something illegal. Go on dark web through Bitcoins and buy something. I mean, you have to put so much effort into it. You're almost defining yourself through that partly. It becomes a bit of an identity. I'm just saying that it has all ingredients to have a lot of experience. I'm not saying it all is, but I think it's important to be aware of that when things are in the early phase and extremely popular, extremely hyped, and have all these ingredients, then we should not just be naively saying that that's enough. No, it's not enough. It has to work beyond placebo before. Otherwise, it will belong and stay in the alternative space, which is also fine. But for me as a scientist and a medic, that we're hoping to find new treatments that can really help people. So fingers crossed that some of these trials. Actually, Olga, can I ask what because you say you're doing this trial, which is really interesting, but I don't think you mentioned for what. Is it a depression trial, just for curiosity?
It's going to be depression and or anxiety, because we often see these two conditions, number one being comorbid, and number two, for both of these conditions, there are reports of potential positive effects of microdosing. So we are putting this as a dual condition there.
Brilliant.
And Dave, if I can take it from here and make some comments on the components of creating the placebo effect. One of the things that I'm excited by running the first trial in Jamaica is that it's far less of a cultural phenomenon there. So there'll be less of the expectations put in by the patients into this trial. So we're hoping that we can minimize that somewhat. And again, taking into consideration all the prior things that were done in your trial as well, we're also controlling for, do you think it's a placebo thing? So we will be checking with people on what they think it is that they're taking. And one more interesting thing that potentially can be tied to the placebo effect, for the full dose trials, we know that specific psychological traits predispose people to better response to psilocybin therapy, or not necessarily predisposed, but they co-occur in patients who tend to respond better. So we are using some of these questionnaires to trace these personality traits and see if that has anything to do with response. And also in our microdosing trials and in our full dose trials, across all our programs, we are looking to conduct a wider omics testing, potentially looking to identify biomarkers for the responsiveness to the either or full or microdosing. And if we can tie back those biomarkers to the personality traits, it's going to be a whole big interesting story.
Sounds very exciting.
Can you mention what traits those are, Olga? Which personality traits?
Yes, so depending on what questionnaire it is, it's either susceptibility or openness to new experiences. There are different traits, different names for the same set of traits depending on what questionnaire is being used. And actually what's interesting is there is some data showing that there are some genetic correlates to some of these traits found through these psychological tools. So it will be very interesting to tie it all together.
Fascinating. So the research is being done in Jamaica, so you're going to have a lot more, I guess, psychologically or psychedelic naive participants, maybe, or especially about microdosing. Are you going to screen for that? Are you going to screen out people who, especially may have heard of this kind of research, like what was done at Imperial College? As that might.
I don't think that we will be blanket asking if people had psychedelic experiences. Just in exclusion criteria, we have 30 or 60 days from the last exposure to area of psychedelic compounds. But beyond that, that's on our participants.
Adam, is there anything you want to add to what's been said?
Yeah, I just want to say in regards to placebo and psychedelics, we've known for a long time that psychedelics are non-specific amplifiers. And we've also known that set and setting are very, very important, even in these smaller doses. You know, Timothy Leary gets credit for set and setting when really it was Al Hubbard who came up with the Hubbard room and making sure people were relaxed and the colors were right and the music was right. And I think, you know, the environment is important even in these small doses. And I think when we get down to doing these trials, that everything needs to be set up in a way where it's even, it's equal, and we can really figure out if it's helping people. But again, the placebo, I guess what I'm saying is the placebo, yeah, maybe there is some placebo happening, but at the same time, we know that if you're going into it and you've heard about it, and like David said, you're amped up about it, I'm sure you're more likely to have something like that help you. So maybe these are also just amplifying, like Olga said, that placebo that's within you. So that's all I would say about that, is we've known for a long time that the set and setting is very important to the use of the psychedelics.
Yeah, and I just want to underscore the fact that I think it's great that all these different ways of exploring these questions are coming up, especially these innovative research techniques, which are only part of the puzzle, and you shouldn't draw conclusions based on one study like this, but still it's intriguing, and it's opened a lot more questions than probably they answered. You know, I think everyone here probably agrees that we can't just summarily say that, you know, there's nothing to microdosing other than placebo. It's all placebo, even though it's. I have to admit the evidence was pretty good in terms of what was shown for Imperial College, but.
And I think it's also important to note, you know, the study they did at 𝗏𝘆liche with pain management and low doses of LSD, and that was double blind. It was 24 volunteers, and they said results clearly demonstrate for the first time in a controlled, rigorous way the positive effect of microdosing on mood, cognition, and pain management. And again, they found out that from 20 micrograms of LSD using the cold presser test, where you stick your hand in ice water, that 1.5 hours after administration, as well as 5 hours after the 20 micrograms of LSD, made people keep their hands in the water 20% longer. So again, I think it's important to call up that study as well. And it shows that these potentially have pain relieving effects and could one day replace opiates as a non-toxic, non-habit forming alternative. So I do appreciate David's study. It's important to not forget the the LSD low dose study with pain from Beckley Research as well.
Thank you. Yeah, unfortunately we're out of time here, but you mentioned 20 micrograms. That's a little bit bigger than a considered microdose. Would that be considered a mini dose? And it's a whole other interesting topic is things between a macrodose and a microdose, and what might be done with those.
Yeah, I think actually on that note, I think it's important to mention that when we talk about microdoses, they are not pharmacological microdoses. Because pharmacological microdoses are much smaller. They are down in only affecting a couple % of receptors. The range that people use in psychedelic microdosing, they have effects that basically have occupancy on the serotonin 2A receptor of 20 to 40%, which is definitely not microdosing in terms of pharmacology. It's defined as microdosing in psychedelic, terminology, but it's probably more like mini doses. And 20 milligram, that people can detect that. We could see that pretty clearly. We could also back calculate the dose of LSD where people could not guess. So that means that the guess was random. We could see what threshold was it. Again, self-reported dosing. So it's not perfect. It's not as good as it will be in Olga studies. I'm really, really glad that you're testing for the guessing, because at least our study has brought that to the table for sure, because that is not convenient thing to do. Not convenient. It's not normal, usual thing to do. Most SSRI trials for depression, they do not ask that. And we are now diving backwards into the history of SSRI trials for depression and trying to apply the same analysis method at the moment to critically relook at all trials where guess has been a part of it, because this has opened so many things also for all old studies done in depression with SSRIs. So it's really good. I'm glad you do it. We could see that 12 microgram LSD is where people start guessing correctly. When you go above that, then that means people are picking it up more and more and more. So 20 people are really good at guessing it correctly.
Thank you very much. I think we have a couple of minutes left. Does anyone want to have any parting words? What are you really excited about? Are you working on anything else other than this that you're really excited about, or you can talk more about the work you're doing with this that you want in the last couple of minutes?
I just came up with a random thought for potential study, maybe for David, but I don't think that ethics would be very favorable on that. If you could give people their typical microdoses and tell them that they are on placebo, what the effects would be then.
Yeah, I agree. There's quite a lot of quite interesting stuff you could do if you can figure out an ethical enough way to do it and have it approved. But because I agree, and yeah, something like that. We have been playing with those thoughts as well. I mean, yeah, and a bit the sort of opposite of what they did in Toronto with the magician kind of thing and the fake full dose story, which was a really fascinating placebo testing there. I think it was in Toronto, McGill, I think. Anyway, yeah, it'd be great. I agree.
Okay, great. Well, thank you all very much, Adam, Olga, and David. You're doing great work, and I'm excited to see what you come up with, Olga, and we'll be keeping an eye out for that. So, thank you very much. Congratulations again, David. Nice to see you again. And Adam, nice to meet you. All right.